Comprehensive dry eye management. The prevalence of dry eye in the male population can reach as high as 10%, but in women, 32% can suffer from this condition. Aqueous deficiency is one group of dry eye sufferers, and evaporative dry eye are another with very little overlap. Nearly 82% fall into the lipid-related group. Gary Fowlkes and Michael Lemp produces a landmark study of dry eye called the DEWS classification. I've modified their diagram to reflect the prevalence of these conditions in our population. Sjogren's syndrome and similar aqueous deficiencies comprise a small amount, while the meibomian oil deficiency or evaporative dry eye are much more prevalent. Dry eye sufferers describe their symptoms in many ways. Some have trouble with contact lenses, some describe glare from their computer, some react poorly to air conditioning or heaters. It all has to do with the tear film, that special layer protecting the cornea from the outside elements. The first step in solving dry eye is to determine precisely the diagnosis. Is it meibomian oil deficiency or aqueous deficiency? One step is to actually measure the thickness of the tear film between blinks, to quantitate. This is done by carefully measuring the distance between the tear-air interface and the tear-cornea interface. This is actually accomplished using a device by Tear Science and a technique known as LipiFlow. Images are reflected off the corneal surface and interferometry used to precisely determine the thickness of the tear film between blinks. The graphs can be shown below. This helps determine the reason for a patient's symptoms. As we look more directly at the tear film, we see the surface is a lipid layer. Think of it as a surfactant or a coating. The first defense against the outside elements. Below that is the more commonly known aqueous layer. The vast majority of patients do not have a problem with the aqueous layer. Instead, 82% have a problem with the lipid layer. To understand exactly where the lipids come from, let's look at the distribution and orientation of the meibomian glands and their apertures, the ducts, on the eyelid margin. These are called the meibomian glands. Let's take a look at the location in a cross-sectional diagram in which the meibomian glands are closer to the eye surface than the lashes or the eyelid muscles. LipiFlow is the first FDA-approved device proven safe and effective against meibomian gland dysfunction. As we transform this diagram into a model of the eye, we can see how LipiFlow works. Heat is applied from the posterior surface of the lid, warming the meibomian glands, demonstrated here, liquefying the material, and gently, rhythmically expressing it out of the lid, thereby cleaning the entire duct system. As you can see, this patient is being massaged during the 12-minute LipiFlow procedure. In almost all cases, this has been described as very comfortable. Before the development of LipiFlow, intense pulsed light, or IPL, was used to treat meibomian gland dysfunction and is still used to some extent today. It also warms up the lipid glands, followed by expression. This is an example of an IPL treatment for dry eye, shown a little faster than it actually occurs. In addition to the two interventional methods for treating dry eye of the lipid variety, we will demonstrate some others. The lipid layer consists of cholesterol, fatty acids, and triglycerides. We have been effective in using warm compresses, oral doxycycline, flaxseed oil, omega-3 supplements, and topical azocyte to improve the lipid behaviors. We've also modulated symptoms using steroids, gels, mists, ointments, and cyclosporin. The aqueous layer is mostly water, but there's prealbumin and a number of elements, including minerals. If you stabilize the lipid layer, you will fortify the aqueous layer. Below the aqueous layer is a third layer known as the mucin layer. Fortunately, very few patients have any difficulties in this area. These microvilli attached to the epithelial cells of the cornea are in the deepest part of the tear film, protected from the outside elements. Your eye doctor examines these areas in the office using a slit lamp. Nearly $2 billion is spent each year treating the 18% of dry eye patients who have aqueous deficiency. The aqueous, or watery component of the tears, is produced in the tear gland, shaped somewhat like the diagram superimposed above. The water flows from the upper outer portion of the eye across the cornea and drain into the tear drainage sac. The tears roll gently across the surface of the eye, distributing itself equally. In order to keep the tears there longer, we block the drain with plugs, either temporary or permanent, as shown in this diagram. The path followed by the tears is blocked so that the tears stay in the eye longer, lubricating the eye more effectively. Permanent punctal occlusion can also be applied for the same effect. And who could forget Restasis and its ever-presence on the television and internet screens? Unfortunately, only the aqueous tear deficiency patients benefit from that drug. One of the tests most effective in determining the effectiveness of the tear film is the tear breakup time, in which fluorescein dye is used to measure the health of the corneal surface and the tear film. Failures in the tear film can lead to permanent damage to the cornea and visual loss. This diagram demonstrates what happens to the epithelial cells and the microvilli when they are exposed to the elements without the protection of the tear film. Layers can actually die and break off, exposing nerves and creating a corneal abrasion. Lubricants can help, but often without the body's spectral mechanisms. With the support of an adequate tear film, these cells cannot be replaced. Mucopolysaccharides and other elements help rebuild the matrix necessary to encourage growth of the epithelium and return of comfort and function of the corneal surface. The microvilli and the underlying epithelium are the last barrier to your cornea and is the only thing beyond the tear film protecting your eye. Addressing the cause of dry eye is not only important for the elimination of discomfort, but also for the improvement of vision, health, and safety. Thank you for listening.